Thank you for tuning in to this virtual presentation for CAR 2020. My name is Blake Linthwaite, and on behalf of our team at the Chronic Viral Illness Service of the McGill University Health Center, I will be presenting effectiveness results for Lost and Found, an intervention to re-engage HIV-positive patients into care. The PIs for this study are Dr. Nadine Cronfley and Dr. Joseph Cox. Un gros merci à l'ACRV de m'avoir invité à présenter notre abrégé. These are my conflicts of interest. At the end of 2017, we conducted an analysis of the cascade of care at the McGill University Health Center, MUHC, and we found that about 10% of patients who had received care in 2016 did not return for care in 2017. This 10% loss to follow-up rate was thought persistent, and we found this to be problematic. Given the negative outcomes associated with being out of care, including health outcomes such as suboptimal adherence to combined antiretroviral therapy, virological failure, development of resistance, hospitalization, and mortality, and health systems costs from secondary HIV transmission and increased hospitalization, this was a priority for our clinic, including nurses. In fact, they had made attempts in the past to identify and re-engage out-of-care patients, including reviewing the full clinical patient list on paper, one by one. However, barriers like competing priorities and limited resources, such as staffing changes and technological limitations, prevented them from fully implementing and sustaining these efforts. This, of course, was our inspiration for Lost and Found, an intervention to re-engage out-of-care patients. This was our attempt to simplify, formalize, and build on the work done by our clinical nurses using an implementation science approach. Lost and Found combines two main evidence-based elements. The first is identifying out-of-care patients, or identifying patients in need of clinical follow-up. The second is contacting out-of-care patients to re-engage them into care. In other words, bringing them back into the clinic. This is a schematic of our intervention, which I'll walk you through. On the left is the first element of our intervention, the identification piece, and on the right is the second element, the contact piece. These colored boxes on the far left are our out-of-care risk prediction tool. Here, patients are classified as high, intermediate, or low risk of experiencing HIV-related outcomes or becoming out of care. These categories were developed collaboratively with nurses and doctors using the DHHS guidelines and adapted to our clinical database. After patients have been placed into one of three risk groups, the clinical database determines how long it has been since the patient's last visit. If they are in the high-risk group, they are marked as potentially out of care after 3 months, 6 months for the intermediate risk group, and 12 months for the low-risk group. All of these potentially out-of-care patients are then placed on an out-of-care list, ordered by risk group and amount of time since their last visit. This list is integrated into the front page of the clinical database and easily accessible to nurses. Up to now, everything has been done automatically by the system. Starting from the top of the list, nurses can then review each patient and determine whether or not they are actually out of care. Through the clinical database, they can then modify out-of-care statuses, change patients' risk group, and document their re-engagement efforts. Once they determine that a patient is indeed out of care, they can start the process of re-engagement. This involves using available contact information to reach patients by telephone. Higher risk patients are prioritized for more rapid re-engagement, including same-day re-engagement if necessary. Additional contact attempts are made every week for the high-risk group, every 2 weeks for the intermediate risk group, and every month for the low-risk group until they are successfully contacted and booked for an appointment, re-engaged, or for up to 6 months, whichever comes first. At their discretion, nurses can decide how frequently to contact patients and how to go about doing so. The aim of this presentation is to report on specific effectiveness outcomes for the Lost and Found intervention. All results presented are from a quasi-experimental pilot study of Lost and Found. This study employed a type of implementation science design called a Type 2 Implementation Effectiveness Hybrid Design, which means that equal weight was placed on assessing implementation and effectiveness outcomes. However, today I will only be presenting the effectiveness results. All data collected for the study come from our clinical EMR database from April 15, 2018 to 2019. I will start by presenting descriptive statistics for effectiveness outcomes, specifically the proportion and count of patients identified as out of care, contacted and re-engaged, or contacted and not yet re-engaged. Finally, I will present some demographic and clinical characteristics for out-of-care patients who were contacted, re-engaged, and or not yet re-engaged. And here are the results. Of the 2,355 patients in our patient pool, 56% were marked as potentially out of care by the system and reviewed by nurses at some point over the course of the year. Of these, 45% were being followed elsewhere for HIV care, 33% were confirmed out of care, 17% were not out of care and thus engaged in care, and the remaining 5% had passed away or could not be accounted for, but they were not out of care. These 231 patients marked as engaged in care after nurse validation differ from those marked engaged in care prior to nurse validation, in that they went without a visit for longer than recommended for their risk category. As a result, They were automatically placed on the out-of-care list by the system, and then removed by nurses. At nurses' request, we made the risk prediction tool sensitive, which means that fewer patients will be missed, and nurses have more opportunities to apply their knowledge of each individual patient's situation and unique HIV care history. Of note, patients who are marked as followed elsewhere or deceased are removed from the active care list until they return for a visit at our clinic. Most of these patients were classified as such in the first few months of the study, which effectively cleaned up the list of active patients and made the out-of-care list much shorter. Among the 443 patients confirmed out of care, 81% were contacted by nurses. Of these, 70% were contacted and re-engaged, 26% were contacted but not yet re-engaged, and 4% were unreachable, usually due to missing contact information. For the 95 who were contacted but not yet re-engaged by study end, 53% were left a message, 33% had an upcoming appointment, 7% were being followed by the clinic's outreach nurse, 4% requested no ongoing care, and 3% had missed their scheduled appointment. Of note, 22 of the 31 patients with upcoming appointments missed their first scheduled visit after being marked out of care. Along with the 13 unreachable patients in the previous figure, the patients who were left a message or missed their appointments will remain on the out-of-care list until they are re-engaged or removed by nurses. Here is a table of baseline characteristics among the 361 contacted out-of-care patients with 2 additional columns, one for patients who were re-engaged and another for those who were not. Across all groups, the median age was about 51 years, about 35% were female, 43 were born in Canada, and 11 had a history of chronic hepatitis C infection. With the exception of CD4 nadir at a median about 236 cells per microliter, all characteristics are relatively consistent for re-engaged and not yet re-engaged patients. Lower CD4 nadirs among the re-engaged could be due to nurses prioritizing re-engagement of patients in higher risk categories. Finally, here is a table of clinical and intervention characteristics for the 253 out-of-care patients who were contacted and re-engaged. The final 3 columns are stratified by risk category. For clinical characteristics, you can clearly see that CD4s and viral loads tend to correspond with the criteria of our risk prediction tool. High-risk patients have the lowest CD4s and highest viral loads, while low-risk patients have the highest CD4s and lowest viral loads. While some go from previously detectable to undetectable viral loads at re-engagement, there are slightly more who slide into high-level viremia, an increase from 11.5% to 14.6%. This increase in viral load is one of the negative outcomes from becoming out of care that I mentioned earlier in the background slides. For intervention metrics, overall, patients were out of care for a median of 315 days. The median time from first contact to successful re-engagement was 71 days after a median of 3 contact attempts. Despite being prioritized for re-engagement, patients in the high-risk group took the longest to re-engage and required the highest number of contact attempts. It's worth mentioning that out-of-care patients were asked to complete a questionnaire upon re-engagement, which we hope will provide further insight into these results, including the delays for high-risk groups. Here's what we learned from these results. First, nurses' early efforts cleaned up the active care list. 653 of the patients they reviewed, mostly in earlier months, are no longer patients of our clinic, and thus don't need to be followed, which will help focus our existing resources. Second, 70% of contacted out-of-care patients were re-engaged, with a median time to re-engagement of 71 days after 3 contact attempts. It took more time and contact attempts to re-engage higher risk patients. These results underscore the importance of multiple contact attempts and how factors not included in our risk prediction tool, like the social determinants of health, might be playing a role in patients becoming and staying out of care. We hope that our questionnaires administered to re-engage patients might shed some light here. Third, 71% of people with upcoming appointments missed their first scheduled visit, highlighting that this represents a challenging population. Clearly, one-off re-engagement efforts are insufficient. Sustaining these efforts is key. Finally, some patients had worsening viral load trajectories, with increases in high-level viremia from 11.5% at previous visit to 14.6% at re-engagement. These increases in viral load are what we would expect for out-of-care patients, but still, we hope to eventually conduct a validation study to determine the clinical significance of these findings, possibly by looking at hard outcomes such as emergency room visits or hospital admissions. First and foremost, we would like to thank patients, especially those who took the time to fill out our questionnaires and provide their feedback. In close second, we would like to thank our clinical nurses. Their names aren't listed here, but they were beyond essential in the success of this project. We would also like to thank the CVAS MUHC clinical and research teams and ViV Healthcare for funding the study as part of their Implementation Science Initiative. On a personal note, I would like to thank Dr. Cox and Dr. Cronfley for this opportunity. And finally, thank you again for having tuned in. If you have any questions, please do not hesitate to contact myself or Dr. Joe Cox by our emails listed here. Stay safe and see you in Halifax for CAR 2021.